ఒకసారి నాకు ఇది కొంచెం చూపించరా ఇక్కడ క్వశ్చన్స్ అయ్యింది
ఫస్ట్ మీరు చెప్పండి మేడం లాస్ట్ చాట్ బాక్స్ లో క్వశ్చన్స్ అడుగు
ఓకే అది ఎక్కడ చూడాలి ఇది స్క్రీన్ షాట్ అది తీయాలంటే
దీని స్క్రీన్ షాట్ తీద్దాం
దీని స్క్రీన్ షాట్
అంటే మీకు కావాలా మేడం
అంటే కొన్ని అవసరం అలా ఏముండదు
అలాగే ఉండదు మేడం యాక్చువల్లీ ఇది రికార్డ్ అవుతుంది వీడియో కావాలంటే
ఓకే మరి అటెండెన్స్ అది ఎలా
ఏం చేయదు మేడం జస్ట్ క్లాస్ అంతా బ్యాక్గ్రౌండ్ అయిపోతుంది
ఎలాగండి
స్టార్ట్ చేసిన స్లైడ్ చేంజింగ్కి ఇది చెప్పడం అంటే మీరు మామూలుగా ఇదే స్టూడెంట్
ఇప్పుడు స్టార్ట్
చేసిన ఈ స్టూడెంట్ అనుకున్నాను అంటే స్లైడ్ చేంజింగ్కి ఆరో యూస్ చేసి స్లైడ్ చేంజ్ అవుతూ ఉంటుంది
గుడ్ మార్నింగ్ today's topic is pediatric coma. So what is coma? Coma has its origin from Greek word coma, meaning deep sleep. It's an alteration of consciousness in a person appears to be asleep, cannot be aroused even by painful stimuli, and shows no awareness of the environment. So normally we see a child after a traumatic head injury or a case of acute fever or acute meningitis, the child goes into coma. So how we diagnose that the child is in coma? The Gcse is usually less than 8 and the child cannot be aroused. He'll be in a state of deep sleep and he'll not be aroused even on painful stimulus. So this is an acute life-threatening neurological emergency. Prompt intervention is needed for prevention of life and brain function. So disorders of consciousness, lethargy. I'm sorry, I could not keep one more. There is delirium. So delirium is clouding of consciousness. And after that comes lethargy. This is difficulty in maintaining aroused state. So the child is usually drowsy and patient can be aroused with difficulty. And obtundation is nothing but prolonged lethargy, and this is decreased arousal but responsive to stimuli, cannot be fully aroused. So stupor is responsiveness to painful stimuli but not to any other stimuli. So coma is totally unresponsive to any painful stimuli. Okay. So according to this, as and when we get a case in the casualty, we can grade the child into these states. Okay. So coma mimics. So we should not be confused from coma and these other causes of these other coma mimics. So example, complete paralysis. This is seen in GBS and botulinum, and akinetic mutism, that is seen in frontal lobe lesion, in which tone and reflexes are intact, and also in catatonia. Etiology: consciousness can be diminished or abolished by dysfunction within the brainstem, impairment of both cerebral hemispheres, insults that globally depress neuronal activity. Unilateral cerebral lesions may cause coma if they compress or injure contralateral brainstem structures. So coming to the causes: infection, meningitis, encephalitis, brain abscess. Toxins, higher doses, toxins can be narcotics, and higher doses of anticonvulsants and antihistamines. Trauma, as in cases of shaken baby syndrome. The shaken baby syndrome, it usually affects children less than 2 years of age, and in which the cerebral vasculature, especially the cerebral microvasculature, are not completely developed, and as soon as we put more force on the baby and shake her head, they'll be bleeding intracranially. Okay. And intracerebral hemorrhages after any trauma, and concussion injuries in the brain. After this comes hypoxic ischemic encephalopathy, that is seen in case of near drowning, cardiac arrhythmia, co-intoxication with toxins, and after strangulation. And epilepsy, as in subclinical status epilepticus and postictal states. So stroke, arterial ischemic stroke, and sorry, and sinovenous thrombosis and hemorrhage. So stroke is usually not very prevalent in pediatric age group, but it do occurs. It is very rare. Okay, and metabolic derangements, as in case of hypoglycemia, hyponatremia, hyperosmolality, and hypercapnia. Hypoglycemia is very common in the neonatal age group. As we see, a baby is very prone to hypoglycemia in the after the first 3 hours of life, and continuous feeding should be done. Okay, and hyponatremia is also very common in the neonatal age group. So pupillary reflex. If both pupils are equal in size and react to light, this means patient is not in coma but may be lethargic and under influence of drug. Okay, so in lethargy, pupils are normal in size and they react to light. So pinpoint pupils seen in opiate overdose, damage to pons, and pinpoint pupils reactive to light bilaterally. One pupil is dilated and unreactive to light and the other is normal. This means damage to oculomotor nerve or possibility of vascular involvement is there. So both pupils dilated and unreactive to light. This could be due to overdose of certain medications, hypothermia, or severe anoxia. So this is a Gcse scale. This is how we grade, we say if the child is in coma or not. So this Gcse has 3 components. And it is also subdivided according to their age. Okay. So it has 3 components. One is eye opening, second is best motor response, third is best verbal response. So the minimum score that we can give to a patient is 3 and the maximum is 15. So in minimum the child is in deep coma, anything less than 5 is in deep coma, and 15 is normal. Okay, so the first component is eye opening. It is one is no response, 2 is eye opening to pain, and 3 is eye opening to verbal command, and 4 is spontaneously. If it is less than 1 year, 1 is no response at all, 2 is to pain, 3 is to shout, and 4 is spontaneously. So next comes the motor component. For a child more than 1 year of age, 1 is no response, 2 is abnormal extension, 3 is abnormal flexion, 4 is flexion withdrawal, 5 is localizes pain, 6 is obeys to commands. So in a child less than 1 year, 1 is no response, 2 is abnormal extension, and 3 is abnormal flexion, 4 is flexion withdrawal, 5 is localizes pain, 6 is spontaneous movements. Okay. The third component is verbal response. So in verbal response, it is graded according to the age into 3 different columns. So 0 to 23 months, 1 is no response, 2 is grunts, 3 is appropriate crying and screaming, 3 is crying, and 4 is coos and smiles appropriately. So 2 to 5 years, it is no response, grunts, 2 is grunts, third is cries or screams, fourth is inappropriate words, and 5 is appropriate words and phrases. And more than 5 years old, 1 is no response at all, 2 is incomprehensible sounds, 3 is inappropriate words, 4 is disoriented and converses, 5 is oriented and converses. So this is a picture showing decorticate rigidity and decerebrate rigidity. So decorticate rigidity, problems with cervical spinal tract or cerebral hemisphere, and decerebrate, it is an extensor position and problems with midbrain or pons. So these fall into the GCS. I mean, these come in under GCS. Okay. So investigations. So what are the emergency investigations we should get? Get done as soon as we get the child. So first, as and when we put a cannula and just after we put a cannula and we start fluids, uh, I mean, in between these two, we take some important blood samples. So on an emergency, we check GRBS, and after that we go for CBP, CRP to see if there is any infection, if there is any anemia or thrombocytopenia, etc. And along with this, we go for serum electrolytes, and these are the emergency drugs. I mean, these are the emergency investigations, and we take a little time and go for the rest of them. Okay, so the first one is so under routine investigations, WBC and coagulation screening, along with the chest X-ray if there is any pathology of the chest, or if the parents give any complaints of respiratory tract involvement, and neuroimaging, that is CT brain and MRI. After that, it is a ABG, blood glucose, serum electrolytes, including calcium and magnesium, and LFT and RFT should be done. In case of uremia, the child is in altered consciousness, and by doing RFT, we can know that. And hepatic involvement and hepatic failure also causes coma. So by doing LFT, we can get the base LFT levels by which we can see if there is any involvement of the liver or not. All these tests are done only to find out where the lesion is. Okay. So serum and urine osmolality should be done. Urine for sugar, ketones, pH, and infection screening along with virology should be done. And special investigations like EEG and ECG should be done. And CSF analysis should be done in case of any suspected meningitis. And serum ammonia lactate pyruvate is in suspected metabolic disorder should be done. And thyroid function tests along with toxic screening and lead levels. Skeletal survey can be done, and GI contrast studies can be done. So first is we go for the routine investigations, and only after that we go for the special investigations. So management. So assess the airway, breathing, and circulation. And if there is any compromise of the respirations, then intubate the child. And if there is a GCS less than 5 or 5, we generally go for intubation, because less than 5 it indicates coma. So we intubate the child irrespective of the respiratory status, and we go and stabilize the cervical spine, obtain IV access and start fluids appropriately. And in case if there is any hypoglycemia, we go for correction of hypoglycemia, or if there is any electrolyte abnormality like hyponatremia or hypokalemia, we go and correct them. And after that we go for routine fluids, and BP should be maintained. So BP should be checked as soon as we get the case, as a and if there is any abnormal BP, then we go for correction of BP by giving IV fluids, and then we can go for inotropes like dopa, dobutamine, adrenaline, depending on the status of the heart. So assess and treat for immediately correctable causes of coma. As I told you, we should search for causes like hypoglycemia, any altered electrolyte level, and just a second, or any hypovolemic shock, or any infections as in case of meningitis. We should start off immediate treatment, give the child the first dose of third generation cephalosporin, or if the child is from malaria endemic area, we can start off IV antimalarials also, because there will be increased incidence of cerebral malaria in such children. Or so prophylactically, we start with third generation cephalosporin, an antimalarial, and also an antiviral drugs. In case we are not able to make out in the initial exam, in the initial presentation, what the cause is. These are only prophylactically, and later on, once we get the cause, we can taper the antibiotics which are not needed, or we can add more antibiotics if it is necessary. Okay, so correct GRBS or any electrolyte abnormalities. So for correction of GRBS, we usually go for IV 10% dextrose, and or sorry, IV 5% dextrose or DNS. We usually don't give 10% dextrose intravenously in children because it is hyperosmolality, because of its hyperosmolality. So assessment of depth of the coma, GCS in older and modified GCS in children above, in children below 5 years. Both these would, I've kept a slide on GCS for elder people and for younger ones, okay? So, assessment and treatment of raised ICP. The focus of contemporary ICP management has changed in recent years in two different aspects: increasing emphasis on CPP management in addition to ICP control, and increasing recognition of the potential for overzealous hyperventilation to aggravate cerebral ischemia by reducing cerebral blood, CBF. Okay. So anti-seizure medications, we give prophylactic anti-seizure medications as soon as, I'm sorry, convulsions can cause massive increases in CBF, and consequent increase in ICP can lead to secondary brain damage and may precipitate or be precipitated by cerebral herniation. Apart from GTCS, some comatose children may have non-convulsive seizures manifesting as eyelid twitching or nystagmus. So neuroimaging, urgent imaging may be needed in a febrile coma and the presence of focal signs or papilledema, as the diagnosis includes stroke, IC bleed, tumor or hydrocephalus. CT, MRI or cranial ultrasound may be needed. So in emergency cases, we usually go for CT scan, and in any chronic cases, like in order to find out a specific lesion, etc., we go for MRI. So lumbar puncture in case of any suspected case of meningitis, whether it can be bacterial, viral or tubercular, we go for lumbar puncture. So we do this lumbar puncture in between L3, L4. And for a neonate, 2 cc syringe needle is enough. And depending on the age, we use a 10 cc syringe or a pure LP needle. Okay. Choice of empirical antibiotics. Empirical antibiotics should include acyclovir in addition to a third generation cephalosporin, and along with an anti-malarial if the child is from endemic area, malarial endemic areas. The need for anti-malarials and antimycoplasma therapy is as and when required. Okay. Fluid therapy, there is accumulating data that hypovolemia worsens outcome in children in meningitis, malaria, and severe head injury. Hypovolemia can lower CPP and lead to worsen ICP due to autoregulatory vasodilatation. So hypovolemia should be restricted. Prognosis, cause of altered mental status should be known. Early initiation of appropriate treatment. So cause of altered mental status, like in some cases it is very easily treatable, as in case of hypoglycemia, hypocalcemia, hyponatremia. These are easily reversible. As soon as we identify the disease and we correct, the child is out of danger, and we should only monitor the child for 2-3 days, and then we can discharge him, and then supplement him with with what he's deficient with. Like in hypocalcemia, we give him long-term calcium supplementation, and for glucose hypoglycemic seizures, we ask him to take frequent feeds, and in hyponatremia, we ask him to take more salt. Okay. So, but in cases of CNS tumors and all, it is prognosis alters according to the type of lesion. So as in case of easily treatable tumors, it can be, it is only the prognosis is better, and in severe cases, like as in case of tumors in medulloblastoma, etc., it is bad. The prognosis is bad. Okay, children have a better prognosis than adults. This is in general. Okay, that's it. Thank you.
ప్రెజెంటేషన్ కావాలి మేడం, మీకు ఏం కావాలి?
అంటే వాళ్ళు అంటే స్క్రీన్ షేరింగ్ మళ్ళీ స్టార్ట్ చేయండి.
ఇది మేడం స్క్రీన్ షేర్.
ఓకే, ఈ డౌట్స్ ఎక్కడ చూస్తానండి?
మీకు డౌట్స్ అంటే
వాళ్ళు టైప్ చేసి
అది యాక్చువల్గా డిజేబుల్ చేస్తారు కదా మేడం, చాట్ ఎనేబుల్ చేశారా మీకు? యాక్చువల్గా ఎందుకంటే మేడం అదేంటి
ఇవాళ మార్నింగ్ కూడా ఆన్లోనే ఉన్నట్టుందండి డౌట్స్ అడగటం.
అంటే కాదు, చాట్ డిజేబుల్ చేశారని అన్నారు అనమాట. చాట్ ఎందుకంటే యాక్చువల్గా మొన్న అంటే చాట్ డిజేబుల్ చేసామన్నారు మేడం, మరి ఇవాళ ఎనేబుల్ ఉందో లేదో నాకు తెలియదు.
ఇవాళ మార్నింగ్ కూడా వచ్చిందంట మా హస్బెండ్ క్లాస్ మార్నింగ్. ఒకసారి అతను ఉంటే
వేరే క్లాస్కి వెళ్ళాడు మేడం.
My call is getting disconnected automatically. ఇది స్టూడెంట్స్ ఓకే ఇదే అనుకుంటాండి.
దీంట్లో ఏమన్నా మెసేజ్ ఏమైనా వచ్చినాయి మేడం ఇందులో?
వస్తున్నాయి.
ఇది స్టార్టింగ్ అదే. ఎందుకంటే యాక్చువల్గా ఏంటంటే మొన్న గైనకాలజీ క్లాస్లో స్టార్టింగ్ ప్రాబ్లమ్ ఉంది, రకరకాల డిస్కషన్ అవుతున్నాయి అని చెప్పేసి చాట్ డిసేబుల్ చేసేసాం. ఆ రోజు అనుకున్నాం అనమాట. మరి వాడు ఎనేబుల్ చేస్తారా లేదా అనేది ఆ రోజు అనుకున్న ఇన్స్ట్రక్షన్. మరి ఈ రోజు సంగతి నాకు ఐడియా లేదు. మీరు ఇలా చూడండి మేడం, ఒక ఎవరో వస్తారు. ఎందుకంటే మీకు ఇది ఎలా చదువుతుందంటే చూడండి, ఎవరైనా ఒకసారి చూస్తా ఉన్నారు ఈ లోపల వాళ్ళు.
ఓకే ఆటోమేటిక్లీ అండ్ Uh, అయిపోయింది నేను ఇది ఇంతే కదా
అంతే మేడం. అంతే మేడం.
సార్ పెట్టారు మధ్యలో సో ఇది వాళ్ళ కాల్ డిస్కనెక్ట్ అవుతుంది అని ఇచ్చారు మై కాలేజ్
ఆ టెక్నికల్ తర్వాత చూస్తారు మేడం. నేను మామూలుగా వాళ్ళకి ఏదైనా ఆన్సర్స్ చేశాను మేడం. అది మీ టెక్నికల్
ఓకే నేను ఈ పర్సన్ కి రిప్లై చేయాలంటే ఎలా అండి పోస్చరింగ్
అంటే ఒక్కరికి రిప్లై చేయడం ఉండదు మేడం. ఇక్కడ టైప్ చేస్తే మొత్తం అందరికి వెళ్ళిపోతుంది.
ఓకే, ఇక్కడ వరకు వదిలేండి మేడం. ఇదంతా నేను చాట్ చేశాను వాళ్ళతో.
ఓకే సో ఇది రండి ఓకే
మేడం అది వాళ్ళగా చెప్పినా పర్వాలేదు. మొత్తం అందరికి షేర్ అయిపోతుంది.
ఓకే
300 షేర్ అయిపోతుంది మేడం.
ఓకే
టైప్ చేయట్లేదు. వాళ్ళగా చెప్పేసినా కూడా ఆటోమేటిక్గా అందరూ ఆ క్వశ్చన్ అందరికి షేర్ అవుతూ ఉంటుంది. అందరికి ఆన్సర్ అయిపోతుంది.
So explain posturing once more and decorticate rigidity. This is total flexor. The child is in total flexor position. I mean, all the limbs are in flexion. So this is seen in flexion, and this is seen in hypotonia. This is usually called as a pitted frog posture. And the other one is decerebrate rigidity. That is total, all the limbs are in extended position, and this is due to hypertonia. Okay. Any more doubts? So examination of a child in coma, we go for a normal CNS examination. That is, we check for bulk, tone, power, and reflexes, and we check bilaterally for pupils. Yeah. Yes. Any more doubts? Okay. Thank you. Yeah, that's it. Thank you.
Float channels now.